Thanks for joining us again. This morning, we are about halfway through our series on your patient with diabetes, cases and discussions. Thank you, Rick. So this is just some basic information about assistance and contact information, which you should have already. So this morning, of course, I'll be facilitating. Jessie Lewis is not here with us this morning, so I'll be taking her role. Our lead discussants, I think, are really important because the two cases touch upon some critical issues. And I've always been mystified by the patient who is on two types of insulin, metformin, a GLP-1 agonist, and an SGLT2 inhibitor. It still has a hemoglobin A1C of 13. And I wonder what exactly is going on. So I'm really pleased that Karen is going to be discussing both of our cases. And of course, Jim has a great perspective on behavior. But our didactic presenter is going to be Adam Perzynski, who's going to talk about diabetes in minority populations and diverse populations. And our two cases are going to be presented by Angelique and Mohammed. These are our disclosure statements for today, and they apply to other sessions as well. And a reminder once again about language, and please it does take some practice to get accustomed to it, but please do use these particular terms whenever you can. Okay, so Adam, take it away. We have a lot of slides and a lot of case material, so I may have to nudge people to move along. So please don't think it rude if I ask you to move along. I think our cases are quite lengthy as well. So Adam, please go ahead.
Well, I'm going to talk to you guys today a little bit about diabetes and health disparities, specifically racial and ethnic disparities. The work I'm going to share today is co-developed by Dr. Joshua Joseph from Ohio State and I. He's not able to be here today, but just so that you know, a lot of the credit goes to Dr. Joseph. So our objectives, as I mentioned, we're going to talk a little bit about how blood pressure, diabetes influence minority populations in the United States. I'm going to give a general description of some key factors that drive cardiovascular risk and heart disease among racial and ethnic minorities. And then also talk about some brief strategies that can really sort of help to prevent adverse outcomes. So one of the most critical things to be aware of, and this is sort of a complicated slide, but if you look at the arch here that I've created from left to right, what we see across the research literature is that severe racial disparities span the full continuum of diabetes, illness, and care, meaning that we see gaps in who gets and has diabetes. We see gaps in detecting and diagnosing diabetes, especially among African American women are more likely to go undiagnosed than other groups. We see some gaps in clinical care processes, in self-management, so in who takes their medicine and who follows through with behavioral recommendations. We see some differences in the severity of disease just based upon the sort of overall burden and severity of diabetes. We see differences in who has hyper or hypoglycemic events, like turning up to the emergency room with those very high or very low blood sugars. We see differences, and so, we've talked quite a bit in the series already about differences in glycemic control as measured by A1C. There are big differences in complications of diabetes, who needs an amputation, who has eye problems, who has other sort of vascular issues, who has cardiovascular events in diabetes, and who dies from diabetes. So the burden of diabetes disparities is severe, and that is somewhat unique among chronic conditions, where we don't typically see this cascade of racial disparities gaps across all layers of a condition. Many other conditions, it's sort of more nuanced and selected across that arch. And I've placed in the middle, then you've been able to look at some of the recommendations from the American Diabetes Association. And so 3 of them that they list here are that we should address social context. Patients should be referred to community resources for their social needs. and that we need to do everything we can to support patient self-management, particularly through the use of health coaches, community health workers, and navigators. So this slide is just a quick highlight on some of my local work. And so, it's sort of meant to illustrate the incredible sort of population health importance at large for us to focus on something like glycemic control and diabetes self-management behaviors. And so what you see here are what we did was for using data on a population of more than 3 million patients in Northeast Ohio, so a 14 county area of Northeast Ohio, we estimated for every neighborhood in the region, the number of quality adjusted life years that we can save if we take various public health strategies, and we compared those things. And so if you read across the x-axis there, you can see there's a huge benefit, almost 1,000 life years if we reduce the number of smokers in the Huff neighborhood by 20%. But in the middle there, what I've highlighted with the call out is that if we increase the rate of persons with diabetes who have glycemic control, so if we could have a 20% improvement in that in just one neighborhood in Huff, that is more effective at preserving life years than any public health strategy in practically any other neighborhood in all of Northeast Ohio. Here we compare it to Lyndhurst, but it's a single strategy that has massive improvements. And so this slide is really just meant to sort of put forward this idea that disparities gaps are so large that even relatively modest improvements can have tremendous impacts at the population level. So I'm going to walk you through a very quick exercise of the 5 whys. This is a simple approach to I credit Chris Jordan from the GRC and Ohio Department of Medicaid Prior Projects that helps you really sort of ask the question why 5 times in thinking about a circumstance that a patient has when they're in front of you, and in getting to sort of the root cause of the problem. It's a simplified form of root cause analysis. And so here we see a patient who didn't take their medication that we prescribed. Maybe they're not taking their metformin. And if we ask why, well, we note that, they actually didn't get their medicine refilled. Well, why didn't they refill it? Well, actually, this patient is on a plan that's on the insurance exchange, and they have a reasonably high copay for their medicine, and they didn't have the money to make the copay this month. Well, why didn't they have the money? They spent all of their money on their housing costs this month. Why would that have happened? Well, the lot rent for their patients for their mobile home went up by 30%. Well, why would that have happened? 30% increase in housing costs in a month is not something most of us are used to. But what we know is that housing costs for low-income families in Ohio are often proportionally larger than for middle or higher-income families due to changes in property investment strategies that raise the cost of housing to benefit investors. And so we see these changes in housing costs. I know that in the neighborhood near where Metro Health is, where I work, more than half of the residents spend more than half of their money on housing every month. So people are spending 50 to 60% of their monthly income. So even a relatively small increase in costs can lead to the inability to pay for a medicine. So I think this is a nice way of doing root cause analysis, and I'm going to give some other examples of root causes and then some strategies that we might use to address those. This is a model from Dr. Joseph's recent paper in endocrinology and metabolism. It's a theoretical model to help sort of guide the way we think about disparities and where they come from. And when I see this model, I really see sort of two columns to this model under those sort of big blue boxes. And one column is the stuff that on the left, it's the stuff that happens in the building, right? So these are things that the medical care system really has a lot of control over. Some of those are historical, but some of those are present day. So the context in your clinic are things that you do have a lot of direct control over. And then the others are more community-based and structural social conditions. that while medical professionals can have some influence on them, that's sort of a broader contextual influence on disparate outcomes in diabetes and cardiovascular disease. So one of the key drivers there in the building component of the model is communication between healthcare providers and patients. And so what we know is that and we've seen this highlighted over many of the cases over the past several weeks, that diabetes self-care behaviors are really, really essential to management of the disease, right? There are only so many things you can do for a person when they're in front of you in those precious minutes when they're in the office. But a lot of the work has to be done when folks are at home, out on their own. And so communicating those facts and working with patients to get them closer to optimal self-care behaviors is critically important. Unfortunately, what we know from the past 2 decades of research on clinical communication with patients is that there are important communication disparities gaps, whereby racial and ethnic minorities and persons of lower socioeconomic position tend to report on post-visit surveys that their communication was far less good than other groups. And so here you can see in the right pane, you can see the black dotted line are persons with the lowest levels of income living below the poverty level. More than 15% of them at most waves reported that their communication was poor. Versus just 5% of high income persons, so 3 times the number. While the gap isn't quite as large by race and ethnicity, we see a similar gap for African American and Hispanic patients with their clinicians. Next slide, please. So one of the things people often ask when confronted with that data, well, how important is it that patients have an encounter where they share the racial or ethnic characteristics that they have with the characteristics of their provider? So does a person who is Mexican American benefit from having a Mexican American clinician, for example? And what we know is from review data is that there is not a lot of great evidence supporting that concordance improves or is associated with more positive outcomes for racial and ethnic minority patients. There were a couple of studies that showed some benefit, but in general, what we find is that communication between the care provider and the patient is actually the sort of secret ingredient here. And so that when communication with providers is rated more highly, that sort of overcomes any racial or ethnic discordance or mismatch in that relationship. And this has actually even been confirmed in experimental studies where we randomize folks to various communication strategies, which have shown that providers who practice empathy and collaborative communication and self-disclosure can build similar levels of trust with their patients as those who share the same race and ethnicity as the patient. Next slide, please. So I want to talk about, one of the undergirding themes of this entire series has been social determinants of health and talking about patients' social needs. So I'm going to give just a teeny tiny description of how this has a bearing on disparities. Next slide, please. So this is a figure from a paper that I did with collaborators at Cleveland Clinic a few years ago. And so this is a map of about 200,000 patients in Northeast Ohio, organized by their levels of neighborhood socioeconomic position, where the reddened areas are the areas with the lowest socioeconomic position, and the green, dark green areas are those with the highest socioeconomic position. Next slide, please. And here what we see is that the image looks almost the same when we look at the person's risk of having or dying from a heart attack or stroke. And when we mathematically estimate those relationships, one of the notable things that we find is that clinical factors like blood pressure, diabetes, and smoking tend to underpredict cardiovascular events, especially in neighborhoods characterized by the lowest levels of socioeconomic status. We also found that neighborhood socioeconomic position on its own, without any clinical indicators in a model, accounted for almost a third of all of the regional variation in who has cardiovascular events, compared to just 10% being accounted for by those typical clinical risk factors in the American Heart Association, American College of Cardiology pooled cohort equation. Next slide, please. This is a map for the state of Ohio, so you can get an idea. This is the same measure that we used, or a similar measure that we use in the paper. And you can see that across the state, so regardless of what sort of quadrant of our state you're in, we see some of these major differences in socioeconomic circumstances. The other thing that we know from recent work in just the past couple of years that has been somewhat ambitious at care organizations across the state in asking patients about their level of social needs is that the burden of social needs is particularly high among Medicaid populations. So this is data from all patients at Metro Health, where we see really just sort of tremendous burden of social needs, with more than a third of patients in most age groups suffering from food insecurity, and more than a quarter having high levels of daily stress. In some age groups here, 1/5 or more had no internet, and about 1/5 across all age groups really have unreliable access to transportation. So we know that the socioeconomic circumstances at the community level often translate to a high burden at the person level. Next slide, please. So I'm going to talk about some simple strategies lastly here and quickly to go through what some basic strategies of how to address disparities that you can think about in your own practice. So one general approach that's emerged as a standard is to really pursue cultural humility, not just sort of cultural competence, but really taking an interpersonal stance that orients yourself towards others and their cultural identity. I think this assess framework by Sherry Burnett Bowie is pretty fantastic. It's about asking questions humbly, seeking self-awareness, suspending your judgment of others, not judging them for their inability to take a medicine or follow through with a recommendation, simply being kind and showing compassion, providing a safe and welcoming environment, and really meeting patients at their level. Next slide, please. I'm going to go through this next group very quickly. Next slide, please. So another important pillar of improving disparities is making anti-racism a core value in your organization, really equipping your team to empower populations that are marginalized, and evaluating how you're doing, knowing where the disparities gaps are at your local site in your clinic and how you can do better is really critically important. Next slide, please. Actually, we're going to skip this one. Next slide, please. The culturally and linguistic appropriate services standards, which have been talked about, I think, once before in this group, are critically important. Next slide, please. These standards help to improve healthcare quality and advance health equity. The link is there in the slides for you to just sort of review how your organization is doing according to CLAW standards, and I would recommend a review of that for everyone. Next slide, please. Another step here is to really think about what your organization is doing now in addressing social needs, screening for them and referring them, and what you can do next. Next slide, please. So there are vendor-based systems. You can use the Pathways Hub. There are simple EHR-based screening protocols that are rolled out in every EHR already. And my favorite topic is just to think about the stuff that you're already doing, those home energy assistance programming forms, all of the forms you fill out on a regular basis, and taking seriously those steps that you're already taking that can improve your patient's socioeconomic circumstances simply by signing a form. And next slide. And then lastly, I think community health workers, many of the practices participating have talked about how they already use community health workers or navigators in diabetes care. This is really a critically successful ingredient. Next slide, please. But what we know is that, and one more slide. What we know is that you need a high dose of community health workers to really, what we know is you need a really high dose of community health workers to make an impact. All of the studies that have shown effectiveness of community health workers have had something along a 6-month or greater intervention period, sort of high touch, high involvement of CHWs in the care of patients. So this isn't just reminder phone calls. It's really sort of investing in community health workers on your team and having them work with patients to improve their health. And I think that's about all we've got. And I don't know if there are other solutions people want to take, or if we have time for a quick question. But I'll hand it back to Gautam to, and we can take a look at the chat and maybe get moving with the cases.
Thanks, Adam. Any questions for Adam before we continue? Okay, I had one question, Adam. If you could just make a comment about the role of health beliefs in health disparities. You know, I think a lot of us are trying to convince our patients to get a COVID vaccine, and it's a losing battle in many cases because they've already have certain specific beliefs. And I've had patients who only take their antihypertensives when they feel their blood pressure is up. Do health beliefs play a role?
I think health beliefs play an immense role. I think one of the challenges is thinking about communication strategies. One of the challenges is really getting to the point where we have a shared mutual understanding of where our patients are coming from with those beliefs. My favorite cases in our health disparities book was written by a geriatrician about a patient who was from India, who only spoke Hindi, and her blood pressure and diabetes were just wildly out of control. She sort of said, look, I need to ask someone else for help, and solicited the help of another care provider who spoke Hindi, who really sat down and spent 30 minutes just sort of bonding and talking with this particular patient. And when it finally came down to it, what they found out is that this particular patient was rationing her medicine because she had a cultural value from the particular subgroup where she was from that medicine was a very scarce resource. And you should only be taking it when you were feeling your absolute worst. Filling all the prescriptions monthly, putting them on the shelf and just conserving them. And so the team then explained to her, like, well, that is a gap that we can overcome. So that was something where it seemed like maybe just a simple cultural misunderstanding that led to a major difference in outcomes. It's not always that simple.
So we are going to be starting our spring series, which will be on weight management. Registration is going to be opening very soon. So please watch for that in your email. You will get a post-clinic survey. I hope it's been enjoyable. And we will see everybody next week. It's 9 o'clock on the nose. Thanks, everyone. Bye-bye.